Можно начинать?
Да.
Прямо. Прямо. Все, спасибо большое. Good morning, my dear colleagues. Hope you already can start our lecture for the day. So, the topic for today is extragenital diseases with pregnancy. Extragenital diseases with pregnancy is one of the most important serious problem which we are meeting in our practice, and you will meet it more and more. Extragenital disease with pregnancy has its special importance, social, economical, medical importance, because pregnancy itself is characterized with increased demand during the intrauterine development of the fetus and increased demand due to compensatory physiological changes which are usually taking place during the pregnancy as compensation for the developing fetus. But if mother has some reduction of the functional status, functional activity of some vital organs during the pregnancy because of this increased demand, because of these problems, she may get decompensation. She may be not compensated, not adapted to the newest condition of her life. So, statistically, only 40% of pregnancies proceed without complications, and most of them during the last decade would be related to the presence of extragenital or other term pre-existing diseases. Pre-existing diseases become more and more frequent complication status which is complicating the cause of pregnancy nowadays. According to Russian Federation statistic data, the ages 15th, 16th, 17th of this century, the triad of the most frequent reasons of maternal death was compound with extragenital diseases, septic complications, and pregnancy-induced hypertension. Even instead of hemorrhages were on the fourth place of reasons of maternal death during these decades. We have the same situation all over the world, and it is explained because of improvement of the treatment of patients with extragenital diseases. Number of medical treatment, number of surgical interventions leading to correction of the vital functions of our patients. Thus, female patients become able to conceive, and if they are pregnant, we had to conduct pregnancy, we had to conduct labor. Of course, in this case, we are getting some additional problems and complications, and it means that we need in special problems and special knowledge and ability to make diagnoses and to make treatment. So the risk of pregnancy, which is happening against the background of extragenital disease, depends on specific extragenital disease, depends on its degree, and depends on the clinical condition of the patient. Our main idea, which we had to discuss today, we had to understand what is the influence of the pregnancy to the cause of extragenital disease. I mean, if a patient, for example, with mitral stenosis will become pregnant, how pregnancy may lead to the worsening of her condition, to the worsening of the function of the cardiovascular system. It may lead because of specific physiological changes which are typical for cardiovascular system as it is presented on this slide. And opposite, cardiovascular disorder, problems with microcirculation, problems with blood supply, problems with cardiac output, leading exactly to the complications in pregnancy. And we had to know what are influences of one to another and another to the pregnancy, as we told. It would be our main idea, first of all, and then if we'll understand it, we had to imagine how to make diagnosis, we had to imagine what is the management of this patient to prevent maternal and fetal death, and it is not the only idea we had to say was health. So, we will tell about some types of extragenital diseases today. Of course, it is absolutely impossible during these 2 hours to present all types of extragenital disease you may meet in pregnancy. Thus, we will pay attention to the most frequent diseases. And we will start to discuss problems with different systems, functional systems in maternal organism, with paying attention to the physiological changes, because just physiological changes on one hand leading to improvement of the general condition and development of the patient. On the other hand, if your patient is not healthy pre-existingly, they may, in combination with pregnancy, lead to decompensation. So first of all, we will tell about cardiovascular disorder. It is written here that 0.2 to 4% of all pregnancies in Western countries, in highly developed countries, complicated by cardiovascular disorders. And during the last 3 to 4 decades, we have increasing of the number of these complications in pregnancy, increasing of the number of pregnant women with heart failure, with severe and non-severe cardiovascular diseases, because pre-pregnancy treatment becomes so effective nowadays that we are getting a population of patients with cardiovascular disorders who are getting pregnancy. So pregnancy itself, as I'm already told, causes significant alteration in maternal cardiovascular system, and we had to understand, repeat again, what are these alterations, and then to understand how it would help to accommodate. First of all, we'll pay attention to hemodynamic, hemostatic, and static metabolic alterations during pregnancy related just to cardiovascular system. So these include increase in blood volume, increase in cardiac output, a 30-50% increase in CO occurs in normal pregnancy. In early pregnancy, it is primarily related to the rise of stroke volume. In late pregnancy, heart rate is the major factor. Heart rate starts to rise at 20th week and increasing until 32 weeks. It remains high 2 to 5 days after delivery. We had to remember this point. 20 weeks to 32 weeks, and even would be prolonged within 2 to 5 1 week after delivery, will find consequences. Reduction in systemic vascular resistance and blood pressure is typical for patient, and it is physiological alteration. Systolic blood pressure typically falls early in gestation, and diastolic blood pressure is usually 10 millimeter mercury below the baseline in the second trimester, and I hope everybody know it. Now, decrease in blood pressure caused by active vasodilation achieved through the action of local mediators such as prostacyclin. Prostacyclin release prevalent on the release of thromboxane during the early term of pregnancy, and even during the first half of pregnancy, closer to the liver, it would change to opposite interrelation. But in the first trimester of pregnancy, prostacyclin is rather high. As in about the third trimester, the decreased diastolic blood pressure gradually increases and may get its normal pre-pregnancy level. The heart rate increase its size. The heart can increase its size by up to 30%, which is partially due to dilation. And by the way, due to increasing of the pump function due to increased cardiac output. Pregnancy induces a series of hemostatic changes, which is an increase in concentration of coagulation factors, fibrinogen, platelet adhesiveness, as well as diminished fibrinolysis, which lead to hypercoagulability, and hypercoagulability is accommodation, compensation for further labor delivery, which is characterized with rupture of vessels and bleeding. To decline the volume of bleeding, compensatory hypercoagulation, including all the links of hypercoagulability, starting and taking place throughout the pregnancy. As about summary of hemodynamic changes in pregnancy, I propose to learn or remember to find this table, because most important for us. First of all, we had to understand what just these hemodynamic alterations, as we already told. Cardiac output, stroke volume, heart rate increase, blood volume increase, peripheral vasodilation, minute ventilation, and please more. Pay attention to the term of pregnancy when they are getting its peak. And if you will be attentive, you will understand that most of them appear just at the same interval, 20 to 24 weeks. Thus, if it is 20 to 24 weeks or second trimester, we had to know that when she will get this increasing demand, she may be from decompensation. And this is one of the main ideas how to prevent this decompensation. Before or just at this time of pregnancy, we had to start to make prophylactic treatment, for example. So, as about the cause of cardiovascular diseases with pregnancy, pregnancy and childbirth may be complicated with lead to exacerbation of rheumatic process, may lead to pulmonary edema because of these physiological alterations, lead to progression of chronic cardiovascular insufficiency, appearance of visceral forms of rheumatic process, nephritis, hepatitis, pleurisy, thromboembolism, congenital heart failure in the fetus. This is the cause of cardiovascular disease when these patients conceive and become pregnant. What about the influence of cardiovascular disease on the cause of pregnancy? The specific, typical for gestation, hemodynamic changes of pregnancy may complicate the cause of pregnancy, labor, delivery, postpartum recovery in the woman who is suffering from heart failure. The impact of cardiovascular disease to the cause of gestation is as follows. Preeclampsia, eclampsia, it is not only higher level of appearance, not only higher incidence of preeclampsia, eclampsia but inside the patients with heart failure who are suffering from preeclampsia, eclampsia syndrome, the relative incidence of severe form is significantly higher, comprehensive with a similar group without heart failure. Patients with cardiovascular disorders very frequently present development of gestational anemia, miscarriage, preterm delivery, rather high incidence, intrauterine fetal death as a result of problems with blood supply, intrauterine fetal growth retardation, intrauterine fetal demise, hemorrhage in pregnancy, labor, and abnormalities of labor pains. Rather large list of complications, and pay attention, all of these complications are so severe that any of them may lead to maternal or fetal death. So what are the main aims, goals for the practitioner who is managing patient with cardiovascular disorder? The main aim to minimize the risk to the life of a woman with cardiovascular disease with prolonging pregnancy and then in childbirth. Prolonging pregnancy should not lead to declining of the vital ability of this patient. Thus, we had to make the main decision, is it possible for this patient to become pregnant and carry the pregnancy, or it is exactly impossible. So, obstetrician gynecologists, cardiologists, and their therapists jointly decide the question about the possibility of prolongation of the pregnancy, possibility of carrying the pregnancy. Ideally, women with a cardiac disease should undergo a preconception evaluation to identify risk of pregnancy and need for immediate treatment to improve her cardiac status. This evaluation helps the health professionals and the patient anticipate potential problems that may arise. Within this framework, both prognosis and management are influenced by the nature and severity of the specific lesion in addition to the function classification. The European Society of Cardiology has published guidelines on the management of cardiovascular disease during pregnancy and classified maternal cardiovascular risks. Those who are going to work abroad had to learn this classification by heart. So, modified WHO classification of maternal cardiovascular risk principles. Distinguish four classes: first, second, third, and fourth. First class of risk means that no detectable increased risk of maternal mortality and no mild or mild increase in morbidity. Thus, the risk is low. The second class of risk, small increased risk of maternal mortality or moderate increase in morbidity. Third, significantly increased risk of maternal mortality or severe morbidity. Expert counseling required. If pregnancy is decided upon, intensive specialist cardiac and obstetric monitoring needed throughout pregnancy, childbirth, and the puerperium up to the 2 months after delivery. In not only 2 months, it may be prolonged up to the next pregnancy or throughout her life. And the fourth group of risk factors, extremely high risk to maternal mortality or severe morbidity. Pregnancy contraindicated. If pregnancy occurs, termination should be discussed. If pregnancy continues, care is for class 3. I want you to understand these three group of risks. Third and fourth are very significant. Fourth means contraindication. Pregnancy, patient may refuse from termination of pregnancy. She may not give us agreement. Thus, in this case, we'll manage this patient as group risk 3. Let me try to make it as fast as possible, because our main idea to read it, to understand, to learn. It is order for walking, which is used all over the world. So conditions in which pregnancy risk is first class, means uncomplicated, small or mild, pulmonary stenosis, patient ductus arteriosus, mitral valve prolapse, successfully repeat simple lesions, and atrial or ventricular ectopic beds isolated. You see that it is patient who has the first group of risk. He represented diseases which are included into the group of risk 2, unoperated atrial and ventricular septal defect, repeat tetralogy law, most arrhythmias, second group. The third, and it is written depending on the individual, pay attention to this point: mild left ventricular impairment, hypertrophic cardiomyopathy, native tissue valve disease, repeat coarctation, Marfan syndrome without aortic dilation, and aorta less than 45 millimeters, and aortic disease associated with bicuspid aortic valve. Mechanic valve, systemic right ventricle, phantom circulation, cyanotic heart disease, other. And conditions which are included into the risk factors of the fourth group are presented here: pulmonary arterial hypertension, severe systemic ventricular dysfunction, previous peripartum cardiomyopathy, severe mitral stenosis, severe symptomatic aortal stenosis, Marfan syndrome, aorta dilated for more than 45 millimeters, aortic dilatation more than 50 millimeters in aortic disease associated with bicuspid aortic valve, and so on. And contraindications to pregnancy and potential disorders. Absolute cardiac condition that imperils maternal and fetal outcome. Systemic ventricular dysfunction, pulmonary hypertension, cyanosis, and fetal loss. And relative high-risk pregnancy should be anticipated: cyanotic congenital heart failure, severe mitral stenosis, severe aortic stenosis, Marfan syndrome, and so on and so on. Please read it very attentively and try to understand and remember. Had to be learned by heart if you are walking both. Dependent. You may work as gynecologist, you had to know it. You may work as cardiologist, internist. You had to learn it. If you're working as family practitioner, you had to learn it, because just from the first visit with suspicion for pregnancy, you had to understand that this patient has specific group of risk, 1, 2, 3, 4 group, and start to manage depending on the class. Here is presented WHO recommendation about the management of the patients in relation to the risk factors. Pre-pregnancy risk assessment and counseling is indicated in all women with known or suspected congenital or acquired cardiovascular aortic disease, class 1. Risk assessment should be performed in all women with cardiac disease of childbirth age and after conception. High-risk patients should be treated in a specialized center by a multidisciplinary team. Genetic counseling should be offered to women with congenital heart failure. Echocardiography should be performed in any pregnant woman with unexplained or new cardiovascular signs or symptoms. And before cardiac surgery, full course of corticosteroids should be administered to their mother whenever possible. For the prevention of infective and endocarditis in pregnancy, the same measures as in non-pregnant women should be used. Class 2 and recommendation. MRI should be considered if ECG is insufficient for diagnosis. In patients with severe hypertension, vaginal delivery with epidural anesthesia and elective instrumental delivery should be considered. When gestational age is at least as 28 weeks, delivery before the term necessary surgery should be considered. Caesarean delivery should be considered for obstetric complication indications or for patients with dilatation of the ascending aorta, which is more than 45 millimeters. Caesarean delivery also may be considered in Marfan patients with aortic diameter 40 to 45 millimeter. Chest radiograph with shading of the fetus may be considered in other methods. If other methods are not successful in clarifying the cause of dyspnea. CT scan, electrophysiological and physiological changes studies, shading of the fetus may be considered in selected patients for vital indication. And prophylactic antibiotic therapy during delivery is not recommended nowadays because the risk and the incidence of rheumatic diseases is significantly lower nowadays. But if it is indicated exactly, there are some direct special indications, antibiotic therapy would be administered. We are speaking about refusing of prophylactic for all of cases, antibiotic treatment for patients with cardiovascular disorders. Now, with the simple words, how we are making it in Russia. So, cardiovascular disorder in pregnancy, management in the first trimester. First, as we already told, we had to understand what is the degree, what is the series, how it is serious, what is the severity of the problem, cardiovascular disease, and we had to understand when at 24 weeks, up to 32 weeks, she will get the peak of physiological changes, increased cardiac output, increased volume of plasma, and so on and so on, hypercoagulation. Would it possible to this patient to be saved from decompensation or not? What do I mean? If you've got patient with some type of Marfan stenosis, Marfan disease, for example, and it is 40 to 45 millimeter of dilation, now, at 6 to 7 weeks of pregnancy, she's suffering from some specific clinical features, dyspnea, arrhythmia, it is some tachycardia, cyanosis, and so on. You see that she is suffering, she presenting decompensation. Now, we can imagine that at 24th week, she will have more problem and it will lead to a number of complications. It is only as an example was presented here. So, the first question. Is it possible to this patient, depending on her general condition and the cause of the extragenital cardiovascular disease, is it possible to this patient to carry out the pregnancy and have delivery? Or it is impossible, pregnancy had to be terminated. We have no possibility to terminate pregnancy independent on the patient agreement. We already told about it, but we will make decision. We will try to explain it to the patient. It is now give education to the patient because the risk of maternal death is excessively higher in the third and fourth group of risks. That's why if we decided that it is indicated to make termination of pregnancy, we had to discuss it with her relatives and with the patient, and we had to give you an indication and get agreement. If patient refuses, we had to manage this patient as a group of the third class of risk. We already told about it. So how we are making decision of this question? Patient had to come to your office as early as possible if she's suspecting pregnancy. Before 10th week gestation, we had to confirm diagnosis of pregnancy. We know already how to make it. We had to make the first prophylactic hospitalization. This patient had to be hospitalized into the special hospital, cardiac hospital, into the cardiac department. When wider investigation, examination of the patient would be done, and we will get as more complete diagnosis, including functional status for today and probable problems which may get later. And together with cardiologists, we are making decision pregnancy had to be terminated or pregnancy may be prolonged. Of course, correct management means if I know that my patient is suffering from one or another cardiovascular disease and she's in reproductive age or closely to reproductive age, my main idea not to wait when she will become pregnant, but to prepare for the possible pregnancy, further pregnancy, her future anamnesis. I had to make special treatment. Then when she will get pregnancy, it will not follow with the necessity of interruption of pregnancy. So if pregnancy is contraindicated, and we understand at 10 weeks, from 10 to 12 weeks of pregnancy, if we've got agreement, we had to make termination of pregnancy. Mostly it is done with dilatation curettage as no safety for the patient hemodynamical system. After if patient we together with patient decided to prolong the pregnancy, we'll make close observation of the patient in outpatient department, paying attention to CBS, other analysis and general condition of the patient up to the second trimester of pregnancy. In the second trimester of pregnancy, we're starting to think about the second prophylactic hospitalization because because at 24th week gestation, we know this patient will get the peak of compensatory physiological alteration. For this patient, these alterations may become not physiological. So before 20th week or 22nd week, we had to hospitalize when she's starting to get this peak. We will make additional exam. We will make wide examination of cardiovascular system, wide examination of the condition of the fetus, cause of pregnancy, and we had to make decision with our colleagues, cardiologists, about the management of pregnancy at the second trimester of pregnancy. So the purpose of the second prophylactic hospitalization, re-examination of the patient for making decision of additional specific treatment. And the third prophylactic hospitalization is done at 10, 36, 37 week. It is written 36, 37. You may make it at 34th, 36 week gestation. Plus minus 1 to 2 weeks is not so important, but we had to understand prior appearance of decompensation. We had to hospitalize this patient to understand what is the development of the fetus condition, what is the functional condition of mother, and to make main decision what is the route of delivery, mode of delivery, and what is the time of delivery. Had she possibility to make delivery through maternal passage? Should we need special measures to improve this process of delivery, or we will make cesarean section? Delivery through maternal passage is excessive stress for the patient. It is physical excitement for the patient who is suffering from cardiovascular disorder. Thus, is it contraindicated or not? We had to make decision individually. Thus, the main question which had to be solved at this third hospitalization is question about condition of both patients and about the timing and mode of delivery. Management of labor. At the end of the second trimester, the multidisciplinary team should formulate a plan for the delivery. WHO already formulate management according to the risk class. Additionally, at the end of the third trimester, up to the 30th week, we had to make final decision about the mode of delivery and time of delivery. Vaginal delivery, cesarean section, or vaginal delivery, natural vaginal delivery, operative with forceps application, for example. We will tell about it during our further classes and lectures. So we had to make decision about time and mode of delivery. And if we decided that it is when we choose one or another type mode of delivery, we had to prepare. For example, we decided to have cesarean section, we had to exclude any inflammatory process because it is contraindicated for cesarean section. We hospitalize these patients at 36. We have 2 weeks to make additional treatment of any problems which are appeared additionally, for example. If we decided to conduct labor through maternal passage, again, we have 2 to 3 weeks to improve functional condition of cardiovascular system of the patient, to improve condition of the fetus, oxygenation, improvement of microcirculation, and so on and so on. We have time to choose the most appropriate type of analgesia in labor, and so on and so on. As about mode of delivery, general recommendations are given here as simple in a simple form just for you to prepare for exams. Class 1, natural delivery through maternal passage. Class 2, refer to WHO. Open it again, read it again, understand what is class 2. Class 2, assisted vaginal delivery, forceps delivery by plan, by schedule. Class 3, forceps delivery or maybe cesarean section. And as a conclusion, cesarean section for any types of extragenital diseases is not the most appropriate, and usually it is done by obstetrical indications or because of decompensation. One advantage of cesarean section is severe, comprehensive, with the disadvantages if she will have natural way delivery. It is as a last resort, had to be done as a last resort in patients with cardiovascular disorders or because of appearance of special obstetrical complication when there are no other possibility for delivery. As about anesthesia, adequate anesthesia had to be administered to this patient. Nowadays we use regional anesthesia, epidural, combined epidural anesthesia, which is more appropriate to this patient. If it is need, administration of oxytocin is useful to reduce hemorrhage, and it should be given in a slow intravenous infusion and not as a rapid bolus to avoid hypertension because it is risky just for these patients. When anticoagulation is necessary, especially in vulnerable mechanical valves, warfarin or low molecular weight heparin should be replaced by interfractionated heparin 36 hours before induction of labor. Unfractionated heparin should be discontinued 6 hours before delivery and restarted 6 hours after delivery. These are main principles. I'm trying to make it as fast as possible, my dear colleagues, excuse me, but the volume of information is excessively large. So the next is kidney diseases with pregnancy. The next is are the group of frequent diseases which you'll meet in your practice. Renal disorders in pregnancy can range from asymptomatic bacteriuria to end-stage renal disease requiring dialysis, as being influenced by the physiological changes in pregnancy. Women who have mild or moderate renal disease or a renal transplant are challenging obstetrician and nephrologists with pregnancy. Thus, these physicians must understand the renal diseases and the effect of pregnancy and vice versa, as we already discussed. Thus, pregnancy may contribute to the development of uterine tract infection because of dilation of ureter and renal pelvis and stasis of urine in the bladder and ureter, which are more expressed in term after 20th week gestation due to excessively increased release of progesterone. In the female organism. Therefore, the term 20 to 24 weeks of pregnancy is of high risk of occurrence or aggravation of UTI. So if my patient present in her previous anamnesis some episode of pyelonephritis with successful treatment, when she will become pregnant, I hate to know that at 20 to 24 weeks, she may present exacerbation of this process because of the influence of progesterone, which is leading to dilation of ureters, renal pelvis, and so on and so on. That's why if I know it, I had to make hospitalization and administer some medication to prevent or decline these stasis, to help you to pass successfully this period of time. Did you understand an idea of management of patients with extragenital diseases in pregnancy? So as about renal physiology of pregnancy, kidney increases by 1 centimeter in length and 30% in volume, collecting system increasing in size by 80%, some degree of nephroptosis appear, nephroptosis, hydronephrosis, hydroureter, nephroptosis may not reserved until third to fourth month postpartum. It is rather prolonged situation. And pressure growing uterus may result in pathological reflux. Pathological reflux itself may lead to development of inflammatory process, exacerbation or appearance of a nearest inflammatory process. Glomerular filtration rate increases immediately after conception, up to 50% at peak. Renal plasma flow also increases in early pregnancy, causing the filtration fraction to fall in mid-pregnancy. Similarly, the value for blood urea nitrogen falls. Renal plasma flow increases up to 85% in the second trimester due to an increase in the cardiac output and increased renal vasodilation to the afferent anterolar arterioles. These changes are particularly important as a normal serum creatinine level, which may represent kidney disease during the pregnancy. The higher glomerular filtration rate increases urine clearance, lowering serum uric acid values and the filter load of glucose increase, which may result in the renal glucosuria. Although up to 300 mg per day proteinuria can be normal in pregnancy, values above that may be an indication of worsening pre-existing disease, and so on and so on. By the way, cystitis may present the earliest suspicious sign of pregnancy, earliest suspicion of pregnancy, especially for such categories of patients who already had one or another UTI infection in the previous anamnesis. Thus, the most common complications in pregnancy with the UTI are preeclampsia syndrome, preterm birth, intrauterine fetal distress, dysmaturity, infections, intrauterine fetal growth retardation, intrauterine fetal death. Perinatal mortality rate is about 25%, means every fourth baby born from mother suffering from UTI died. The effect of pregnancy on the cause of UTI, the cause of pre-existing urinary tract infection exacerbates during the pregnancy. Chronic pyelonephritis become acute during pregnancy, and if not treated, it may occur twice or thrice during gestation, followed with excessive inflammatory process in postpartum period, failure of the function. Predisposing factors of appearance of UTI in pregnancy, previous history of UTI, diabetes mellitus, polycystic kidneys, urinary tract calculi, renal tract abnormalities, nephrotic bladder, and drugs, steroids, or immunosuppression. Clinical features: cystitis, urinary frequency, dysuria, hematuria, proteinuria, suprapubic pain. Pyelonephritis, characterized with fever, low pain, and or abdominal pain, vomiting, and rigors. Assessment of renal disease in pregnancy: urinalysis, dipstick for proteinuria, mid-stream specimen of urine for analysis, mid-stream specimen of urine for culture and sensitivity. It should be repeated if it is non-significant or with mixed growth, ultrasound, intravenous pyelography, cystoscopy, renal biopsy. As about management, asymptomatic bacteriuria you may meet it rather frequently in your practice. So, 3-day course of antibiotics orally had to be administered to prevent pyelonephritis development. In case of acute cystitis, 7-day course of antibiotics orally had to be administered to prevent development of acute pyelonephritis. Urine culture following treatment to ensure eradication of organisms, and recurrent bacteriuria occurs in 15% of women in pregnancy and requires a second course of antibiotics. Acute pyelonephritis in pregnancy. As we already understood, most frequently it appears at 20th week due to progesterone release. But if your patient came to office at term, which is less than 12 weeks gestation, with signs of acute pyelonephritis, fever, specific changes in urine analysis, blood analysis, and so on and so on. It is exactly had to be used antibiotics, but in this time of pregnancy, we have no possibility to administer antibiotics. Usually, thus we are making decision about interruption of pregnancy. So here are presented clinical findings: anorexia, nausea, vomiting, fever, itching, pain, micturition, dysuria, and so on and so on. Positive Pasternatsky symptom: bacteriuria, leukocyturia, proteinuria, cylindruria may appear, even in pyelonephritis. Chronic pyelonephritis may start as chronic form or may be due to ineffective treatment of acute or recurrent pyelonephritis. Management of UTI infection in pregnancy. Again, we distinguish groups of risk. The group of first degree of risk: women with acute pyelonephritis occurring firstly during pregnancy. Mild risk: insignificant, especially if it appears after 12-week gestation. We can administer specific anti-inflammatory antibiotic treatment, and both mother and her fetus will not suffer from excessive problems. The second degree of risk: women with chronic pyelonephritis occurring prior to pregnancy and exacerbated during the pregnancy. And the third group of risk: women with pyelonephritis complicated with azotemia or hypertension, or women with pyelonephritis of the only kidney. Usually pregnancy is contraindicated, principally pregnancy is contraindicated for patients in the third group of risk, and especially if this patient is at the earliest terms of pregnancy. But decision final about the termination of pregnancy would be done with a team: practitioners, gynecologists, obstetrician, and nephrologists, patient and her relatives. As about rules of management, UTI infection in the first trimester of pregnancy. As usually in our country, we prefer to make first hospitalization. She may be hospitalized, she may be investigated, examined in outpatient department. By the way, it is not obligatory, but before the 10th week gestation, we had to examine, together with nephrologists, we had to examine general condition of patient, state of renal system, estimate the risk to the mother, life during the pregnancy. In case of prolongation of pregnancy, antibiotic therapy during 7 to 8 days should be started after 12 weeks gestation. And here is presented by WHO the most appropriate recommended antibiotic drugs and doses. Penicillin intramuscular 10 million units daily, or ampicillin 500 milligram 4 times daily, or piopen 1 gram 4 times daily. Please don't forget, in pregnancy, patient has higher volume of circulating blood, higher volume of circulating plasma. Thus, the dose which we administer to get effect of this treatment is sometimes higher than we administer out of the pregnancy, because to get therapeutic effect we had and to get therapeutic concentration, because of increased volume of circulating blood up to 40 to 50%, we had to increase the dose. That's why pay attention to the doses which are used in pregnancy. Management in the second trimester of pregnancy. Again, at 22 weeks gestation, we usually propose to our patient the second prophylactic hospitalization. And the goals are examination of maternal condition, fetal condition, prevention of pyelonephritis, prophylactic antibiotic therapy is indicated in this case, improvement of the function of fetal placental system, prevention of fetal distress and intrauterine fetal growth restriction, prevention of premature labor, and close observation. Treatment regimen for UTI in pregnancy. Oral antibiotics: amoxicillin 500 milligram TDS, cefodraxil 500 mg BD, cefalexin 200 mg TDS, nitrofuran, trimethoprim. Pay attention, please. I prefer to learn it. I prefer to rewrite it, to save it, learn it by heart, because these are recommendations of WHO. And I am almost sure that you will start to make treatment of your patient in your countries just with these drugs. It was management of patient and prophylactic antibiotic treatment. or not only prophylactic, in the second trimester of pregnancy, which is done from 22 to 24, 26 weeks individually. What do we do in the third trimester of pregnancy? The third prophylactic hospitalization had to be done at 34 to 36 weeks gestation, and most of them, if they are hospitalized, they will come from the hospital with the baby in their hand, because no, usually it is prolonged up to the term of labor, but may have other duration of treatment. So the third prophylactic hospitalization aimed on general examination of both patient's mother and her baby inside, choice of the mode of delivery and timing of delivery, prophylactic antibiotic therapy if indicated, especially for those who are going for abdominal delivery by cesarean section. And how we'll make decision about the choice, decisions about the mode of delivery. Now, here are presented main principles. Natural maternal passage are the best mode of delivery, especially for patients with inflammation. The best is delivery through natural pathways. Cesarean section may be contraindicated exactly due to infection, but it may be unusually done if your patient has special obstetric indications. Premature separation of placenta, detachment of the placenta, for example, a placental rupture. Patient is dying from hemorrhage shock. Would I wait that she will die? I will make cesarean section even if it is contraindicated. Firstly, I will try to save her life just now, then I will try to save her life at the next step of management. So, in case of appearance of special indications, obstetrical indications for cesarean section, or it may be done as a last resort when there is severe decompensation. And as about management of postpartum period, antibiotics. Antibiotics had to be, decision about antibiotics had to be done individually, but most patients needing prophylactic antibiotic therapy because low immune defense in this term, because opened very wide post-operative and post-delivery surface, uterus presenting wound postpartum. In combination with low immune defense, in combination with presence of inflammatory process, this large wound, postpartum wound, presenting very, very high risk of development of postpartum non-specific inflammatory bacterial complication. That's why antibiotic therapy is usually administered as prophylactic together simultaneously with uterotonic drugs which are increasing uterine contraction and diminishing the area of postpartum wound. So as a conclusion, UTI infection may be contraindicated for prolongation of pregnancy if there is pyelonephritis of the only kidney, or it is pyelonephritis which is at the very beginning of pregnancy characterized with excessive clinical features, ketosis, acidosis, metabolic changes, and any other situation we are trying to prolong pregnancy. So during the pregnancy we had to make 3 prophylactic hospitalization, and the most appropriate type of mode of delivery is delivery from maternal passage. As about the time of delivery, it had dependent on the fetal condition. When the fetus is prepared, we had to make delivery at any time. As about diabetes mellitus, again, let me pay attention to physiological changes in pregnancy. What are these changes? Impaired insulin sensitivity, increased beta cell response, moderately increased blood glucose level, changes in the level of circulating free fatty acids, triglycerides, cholesterol, phospholipids. In fact, the insulin resistance developing in pregnancy is likely to be a physiological event favoring glucose supply to the fetus. The reduced insulin-mediated utilization, of glucose switches the maternal energy metabolism from metabolizing carbohydrates to lipid substrates, free fatty acids, and redirecting carbohydrates toward the fetal tissue. In early term of pregnancy, first trimester and first half of the second trimester, blood glucose fasting and after meals in pregnant women is somewhat lower than in non-pregnant women. Insulin resistance typically occurs in the second trimester and then increases during pregnancy. The physiological meaning of this phenomenon is the guarantee of an adequate supply of the fetus with glucose. Its mechanism is largely due to the influence of hormones secreted by the placenta. Or in gestational diabetes, changes in insulin resistance are significantly more pronounced than in normal pregnancy, is disrupted and compensatory increase in insulin secretion. Changes in beta cell function occur in parallel with the development of the fetal placental unit and the local production of hormones such as estrogen, progesterone, cortisol, human chorionic gonadotropin, placental lactogen, prolactin, all of these hormones which are released from placenta when it starts its new function. These hormones have been shown to induce insulin resistance. Pay attention to interaction of these hormones. Here is presented the scheme of endocrine metabolic adaptation to meet the energy demand of the fetus. Mother, insulin resistance, followed with pancreatic B cell effect, normal glucose tolerance. In fetus, glucose flow across the placenta increases because of the insulin resistant and patterned by B cell deficit, which is leading to gestational diabetes. Gestational diabetes may appear as a result of involvement of the fetal beta cell to the metabolic process of maternal and fetal organism altogether. Instead of maternal, fetal will start to make function of its pancreatic beta cell deficit, and later it may follow the development of congenital diabetes mellitus. So diabetes in pregnancy is about not exactly classification, but how it is happening and what types. We distinguish pre-existing hypertension, type 1, type 2, and gestational hypertension, which may be pre-existing hypertension was not verified before pregnancy, or it may be true gestational diabetes mellitus. As usually, what is the influence of diabetes on pregnancy? Maternal complications, which are related to the presence of diabetes, are abortions, spontaneous, premature labor, increased incidence of preeclampsia, eclampsia syndrome, hydrangeas, typical complication, and the incidence is up to 50% in all patients with diabetes mellitus. Abruptio placenta, placental dysfunction. Diabetes itself characterized with vasopathia, angiopathia, neuropathia. In all of these problems are responsible for blood supply, fetus development, and so on. So the risk and incidence of such a complication are very high in patients with diabetes mellitus. Complications in labor is about maternal complications. Abnormal labor pain is obstructed labor because of the big fetus and non-correspondence because between the fetal sizes and maternal pelvic sizes. Shoulder dystocia, big fetus, giant fetus, typical for diabetes mellitus. Perinatal injuries, the same reasons. Hemorrhages in the third stage of labor and in early postpartum period because of the problems with hypercoagulation, mostly because of overextension of the uterus due to the big fetus, hydrangeas, and lack of uterine tonicity. In the late postpartum period, endometriosis occur, and the rate of endometriosis is higher than in patients without diabetes mellitus. As about fetal complications, they are macrosomia, diabetic fetopathy, congenital malformation, birth injuries, and neonatal after delivery, secondary asphyxia, respiratory distress syndrome, perinatal infection, so the level of perinatal death is very high. Neonatal complications are a result of fetus suffering during the pregnancy, are a result of the same problems, neuropathy, vasopathia, angiopathia, followed with the lack of microcirculation, metabolic changes, metabolic problems lead to diabetic retinopathy, and progressive fetal distress may lead to the birth injuries without obstructed labor, without excessive physical influence, and so on and so on. So, congenital abnormalities which are associated of the fetus, which are associated with diabetes mellitus, central nervous system abnormalities, spina bifida, anencephaly, holoprosencephaly, hydrocephalus, cardiac transposition of the great vessels, ventricular septal defect, arterial septal defect, cardiointestinal, genitourinary, skeletal, number of congenital abnormalities which of the fetus which are associated with maternal diabetes mellitus. Here is congenital anencephaly shown. Fetus is not viable. Here is spina bifida. If it is delivered already at time closely to the term, it is already not viable. We have a few episodes of successful surgical treatment of spina bifida when it was diagnosed before 24 weeks gestation, and before this term, surgical correction during the pregnancy may be done, but it is very rare. A few only information is present in the world literature. So the cause of diabetes mellitus, influence of pregnancy, diabetes ketoacidosis, coronary artery disease, hypertension, infection, increased rate and severity, nephropathy, polycythemia, retinopathy, vascular changes, and so on and so on. As about screening, please pay attention. Glucose screening test, also called a glucose challenge test or GCT, routinely recommended between 24 to 28 weeks of pregnancy to check for gestational diabetes, and would be better if you will make it for any patient as screening. For any patient who is under your observation. GCT designed to identify as many women as possible who may have a problem and need more testing to find out. Before 24 weeks of pregnancy, GCT is recommended only for pregnant who has risk factors for gestational diabetes, but normally in the cases of screening test or fasting glucose. These factors are obesity, body mass index before pregnancy more than 30 kg, diabetes mellitus of the second type in the immediate family, the violation of carbohydrate metabolism in the post-gestational diabetes in the previous pregnancy, impaired glucose tolerance, and identification of glucose in urine. These are indications for making of this procedure. What is the procedure itself? Patient is given a sugar solution that contains 50 grams of glucose. An hour later, a blood sugar level should be determined. Normal blood value is 7 millimole per liter or 126 milligram per deciliter. Usually we are checking up the blood glucose before taking, then 1 hour after taking. If blood glucose level is 7.2 millimole per liter, 130 milligram per deciliter, the two-step testing is indicated. I propose to learn it by heart, not to get a mistake. Easy. Learn this slide and you know what to do. At term 24 to 28 weeks, make as a screening. You may make for any, and if it is more than it had to be, make two-step testing. Here is presented the scheme of two-step testing. Screening, 50 milligram glucose challenge test, GCT, already done. More than 130 milligram per deciliter in your country. Diagnostic test, 100 gram oral glucose tolerance test, 3-hour oral glucose tolerance test for patient with abnormal result of GCT. During this second test, called the 100 gram oral glucose tolerance test, the blood glucose level would be tested 4 times during a 3-hour period after drinking the cola-like drink. If 2 out of the 2 flu blood tests are abnormal, patient is considered to have gestational diabetes. Abnormal blood values for 3-hour 100-gram oral glucose tolerance test are fasting greater than 95 mg per deciliter, 1 hour greater than 180 mg per deciliter, 2 hours greater than 155 mg per deciliter, and 3 hours greater than 140 mg per deciliter. Obstetric complications. Everybody had to know how to transform milligram per deciliter to millimole per liter, which is used in our country. It had to be divided into 18, index 18. Abortions, obstetrical complications are miscarriage, spontaneous abortions, prematurity, premature birth, increased incidence of preeclampsia, eclampsia, high dryness, abruption placenta, placental incompetence. Complications in labor, abnormalities of labor pain, obstructed labor, shoulder dystocia, we already talked about it, but most important for us, contraindications for prolongation of pregnancy. Severe manifestation of vascular lesions, nephropathic stage of glomerulosclerosis, ischemic heart disease, limb ischemia, and like. Severe manifestation of central nervous system damage or other organs to their functional insufficiency. Severe, according to the United States, contraindications for pregnancy. Severe cardiovascular complications such as symptomatic coronary artery disease or uncontrolled chronic hypertension. Severe vascular complication from the diabetes mellitus, untreated proliferative diabetes retinopathy, or significant renal impairment. Significant autonomous neuropathy, coma, pre-coma state in the first trimester, and concentration of glycated hemoglobin A1C in the first trimester, which is more than 10%. By United States colleagues, obstetrician gynecologist colleagues, it is contraindicated, pregnancy had to be terminated. And as usually, how we are making it. The first hospitalization had to be done before 12 weeks, making decisions about possibility to carry the pregnancy, to prolong the pregnancy, possibility of labor. It will not lead to maternal death, with the simple words. The second, 22-24th week gestation, prophylactic hospitalization, correction of insulin therapy, examine the fetus condition, and rule out, by the way, presence of congenital abnormality of the fetus development. And the third, prophylactic hospitalization at 33-34th week, careful immediate monitoring of the fetus, the treatment of placental insufficiency, antenatal prevention of the distress syndrome, antenatal preparation, decision about the timing and mode of delivery, and delivery. If there are no contraindications for prolongation of pregnancy, special management is proposed. The recommended diet consists in 1,800 to 1,400 kilocalories, made up 15-20% protein, 50-60 carbohydrates, and up to 20% of fat. Insulin therapy should be administered for any pregnant with diabetes mellitus, even with mild form, from the very beginning of pregnancy, just to prevent compromising of the fetal beta cells, to prevent development of congenital abnormality. We had to get insulin therapy to arrest possibility of the fetal beta cells to take part in maternal metabolism, to help to mother, because beta cells will stop to make their biological function. That's why insulin is indicated for any patients. Glucose values should be discussed with the patient and adjustment in the insulin dosing made accordingly. As about insulin therapy, if your patient had pre-existing diabetes mellitus and had used some other drugs, sulfonylamides, some other drugs, medicines which are used, oral anti-diabetic drugs. They are absolutely contraindicated in pregnancy. They are characterized with development of congenital abnormality of the fetus. That's why only insulin had to be changed to insulin as early as possible. Patient who is suffering from diabetes mellitus, taking these drugs, and if she is in reproductive age, any suspicion from the first day of delayed menses had to push her to start to change the property of insulin control, exclude use of oral anti-diabetic drugs. So here is presented the most useful scheme of insulin therapy. The most useful scheme of insulin therapy is combination of a long-acting insulin with a short-acting insulin, 2 injections of a long-acting insulin before breakfast and dinner, and 1 injection of a short-acting insulin before lunch if needed. And another scheme, total daily dose should be divided in half, given every morning and even morning dose before breakfast, 2/3 of the dose given as prolonged insulin peak activity of 5 to 12 hours, 1/3 of dose given as a short-acting insulin. Evening dose before dinner, 1/2 of dose given as a long insulin, and 1/2 of dose given as a regular insulin. And at last, the time and way of delivery. Optimal term of delivery for the patient with diabetes is from 36 to 37 weeks, because after the term, placental incompetence is more progressive due to growing out and the fetus may die. Thus, 36 to 37, it is pre-term. But it is already explained why. Before 36, may be given delivery, may be done delivery, but decision had to be done individually because before 36 week gestation, this fetus is deeply underdeveloped usually, which is known as diabetic fetopathy. It is much better for this patient to have delivery through maternal passage, of course. The most preferable type of delivery for any patient with any type of extragenital disease is delivery through natural passages. Caesarean section is indicated because of the appearance of obstetrical indications and due to some special vascular changes as well as neuroretinopathy, excessive physical excitement in this case may lead to detachment of the retina because of angiopathia. Ketoacidosis, which is happening in pregnancy or during the labor, acute renal incompetence, big fetus, cephalopelvic disproportion because of the big fetus, severe preeclampsia, eclampsia, even in patients without diabetes mellitus are indicated for as fast as possible delivery. We are making cesarean section in this case. Hemorrhage due to placental abruption, placenta previa, vasa previa, expulsion of the umbilical cord loops and so on and so on. Special obstetrical indications for cesarean section which are not dependent on the presence of diabetes mellitus or other disease. And some words about diabetic fetopathy. You had to know it when you will prepare for your class. Please pay attention. What is diabetic fetopathy? Diabetic fetopathy is failure of the fetus which is developed in the uterus of the mother suffering from diabetes mellitus. And what are typical features of diabetic fetopathy of the fetus? Fetus is large, for example, according to the size, expectant body weight, fetus size corresponding to 38, 43 gestation, but its functional development of the lung surfactant system, development of urinary system, and so on and so on. It is delayed, comprehensive with the fetus at this term, but in healthy mother. Its functional condition, development of its systems is corresponding, for example, to 32 weeks gestation, while the size, length, and body weight corresponding to 38 weeks gestation. On one hand, it is big fetus, on another hand, it is deeply underdeveloped. That's why the decision of the timing of delivery had to be done individually, including the results of the fetal condition examination. Next group of diseases, respiratory system diseases. We will tell about bacterial pneumonia, fever, chills, cough, productive, purulent sputum. The most common complaints in bacterial pneumonia. As about pathogens, may be Streptococcus, Staphylococcus, any pathogen, including virus, we know that COVID-19 may lead to viral pneumonia. Here is the viral pneumonia. Clinical symptoms due to influenza infection include high fever, headache, malaise, muscle aches, cough, which usually subsided in approximately 3 to 5 days. COVID pneumonia, viral pneumonia has in some cases similar symptoms, and in other cases may have some other symptoms. Tuberculosis is another type of disease which is characterized as failure of the respiratory system. The incidence of these disease become to be increasing in recent years, possibly because of the increased rate of HIV infection, increased numbers of immigrants from endemic countries, and a decline in public health services. It is especially prevalent in certain high-risk groups. The pregnant patient who is not at high risk for drug-resistant tuberculosis should be treated with isoniazid, rifampicin, and ethambutol for a total of 9 months throughout the pregnancy. We are trying to administer after 12 weeks gestation and continue up to the term delivery in postpartum. If the risk of drug resistance is high, pyrazinamide may be added with the understanding that there are known risks. Pyridoxine should be given to all patients receiving isoniazid to avoid nerve damage to the mother. Vitamins, combination of vitamins of B group is indicated for all of these patients, not exactly pyridoxine had to be administered. As about asthma, asthma have different causes during the pregnancy. Some patients may have no any changing in the rate and intensity of the attack of bronchial asthma. Another patient during the pregnancy may present increasing of the rate of attack and increasing of its severity. That's why just from the very beginning we had to pay attention to individual conditions, to individual properties of the asthma caused during the pregnancy. So, if asthma symptoms develop for the first time during the pregnancy, it is important to rule out laryngeal dysfunction or upper way obstructions, pulmonary edema, gastroesophageal reflux with aspiration, and viral respiratory infection, because it is very important. The diagnosis of asthma is facilitated during the childbearing years by a relative paucity of the other condition that mimic asthma. As a rule, chronic obstructive pulmonary disease secondary to smoking doesn't cause symptoms until the 6th decade of life unless the patient has associated alpha-1 antitrypsin deficiency. As about the management, drugs currently available to treat asthma may be classified as relieved or controlled reliever or controller agents, depending on their principal pharmacodynamic effects. Short-acting bronchodilators such as inhalated beta-agonists are considered reliever agents because they are to be taken for acute symptoms relief to this patient. Corticosteroids, usually as well as sertraline, long-acting beta-agonists are considered controller agents because they are used to achieve and maintain control of symptoms, and they are used daily on a long-term basis. In general, medications that are commonly used for chronic management of asthma may be taken safely for the pregnant patient, and usually mode of delivery, forceps application. Blood diseases with pregnancy, especially important for those who are in there from other countries, because there are a number, the incidence of blood diseases, especially anemia, different types of anemia is rather high in these countries, Mediterranean countries. Physiological changes in blood in pregnancy, plasma volume increasing up to 50%, red cell mass increase up to 25-35%, physiological hemodilution appear as a result of this discrepancy between the increasing of the volume of plasma and RBCs. And it is followed with the imbalance of hemoglobin concentration and plasma volume, followed with the log hematocrit. Mean cell volume increase secondary to erythropoiesis. Mean cell hemoglobin concentration remains stable. Serum iron and ferritin decrease because of utilization Total iron binding capacity increases, iron requirement increases totally, in moderate increase in iron absorption for lead requirement uh, increase and atypical. Types of blood disorders. I will make as short as possible. So, blood disorders are divided into groups. Blood disorders affecting red blood cells, which carry oxygen to the mother's tissue. Blood disorders affecting white blood cells, which fight infection. Blood disorders affecting platelets, which help blood to clot. And blood disorders are affecting blood plasma. The first group and the larger and most frequent group of blood cells, red blood cells disorders, include anemia. We distinguish iron deficiency anemia, pernicious anemia, B12 deficiency, aplastic anemias. In people with aplastic anemia, the bone marrow doesn't produce enough blood cells, including red blood cells. In patient has anemic condition. Autoimmune hemolytic anemia in patient with this condition, an overactive immune system destroys its own body's red blood cells, causing anemia. And anemia of chronic disease. People with chronic kidney disease or other chronic diseases tend to develop anemia. Chronic kidney disease, diabetes mellitus. Blood disorders that affect red blood cells. The second group is thalassemia, sickle cell anemia, typical for Indian population, polycythemia, malaria. Again, in your country, it would be very frequent. Blood disorders affecting white blood cells, lymphoma, leukemia, multiple myeloma, myelodysplastic syndrome, and affecting platelets, thrombocytopenia, idiopathic thrombocytopenic purpura, heparin-induced thrombocytopenia, thrombotic thrombocytopenic purpura, essential thrombocytosis. Hemophilia, these are groups of blood plasma. Hemophilia, von Willebrand disease. Von Willebrand disease characterized with failure of the production of Willebrand factor, which is protein, helps blood to clot. Lack of development of von Willebrand factor lead to some von Willebrand disease. May happen in any country, in any population, and so on, as well as anemia, but most frequently, anemia, you will meet it most frequently. You practice this, we will start from anemia. Well, we have time, we will try to continue its discussion. So, as I'm already told, it is the most common blood disease, one of the commonest medical disorder in pregnancy. In United Kingdom, 15% are suffering from anemia, and 85% of these patients are suffering from iron deficiency. United Kingdom is not low, is highly developed. It is highly developed country. That's why. It is not a South country. That's why what I want to pay your attention for. The incidence mostly dependent on the social economical condition, climate, and so on. But no country where there is no anemia at all, and even in highly developed country, the incidence is rather high. So anemia is a direct and indirect cause of maternal and perinatal mortality, and you see from 17 to 46 up to 50% of maternal death are happening because of directly or indirectly because of the presence of anemia. Definition: anemia is a condition of low circulating hemoglobin in which the hemoglobin concentration has fallen below a threshold lying at 2 standard deviations below the median of a healthy population of the same age and stage of pregnancy. Hemoglobin concentration of less than 11 grams per deciliter and hematocrit, which is less than 33% of packed cell volume by WHO is required as anemia. Hemoglobin, which is 110 gram per liter in first trimester, 105 second, and in the third trimester less than 100 gram per deciliter. Criteria degrees of anemia presented here by WHO, including hemoglobin level, gram liter, more appropriate. No, in our country, we use it not gram per deciliter, but gram liter, and hemoglobin in percent. Normal 140 to 111, and 110 and less are anemias. 110 to 91 first mild degree, 90 to 81 second moderate, and less than 80 severe degree, and respectively declining of the percentage of hematocrit, lack of packed cell volume. So, common types of anemia: nutritional deficiency anemia, iron deficiency, folate deficiency, vitamin B12, then hemoglobinopathy, thalassemia, sickle cell disease, and rather rare type aplastic autoimmune leukemia, Hodgkin, exon, and so on. Practical importance: maternal effect, increased susceptibility to infection in pregnancy if she's suffering from anemia, reduced physical capacity, poor tolerance of blood loss, increased probably blood transfusion, increased postpartum depression, preterm labor, preterm delivery, preeclampsia, rupture of placenta, death, twofold increase in patients with anemia. Pregnancy outcome: increased rate of prematurity, intrauterine growth retardation, placental abruption. It may lead to increasing of the rate of cesarean section and lead to increasing of the rate of cesarean section because of so severe complications. So, fetal effects: intrauterine growth retardation, low birth weight, prematurity, anemia in infancy, neural tube defects, impaired psychomotor, mental development. As about standard of care, all women should be offered screening for anemia. Screening should take place early in pregnancy, as we already understood that before 12 weeks. First prophylactic hospitalization may be done, may not be done, but the special management treatment in a special examination had to be done obligatory. And at 28 weeks, we are making third time before delivery, timing and mode of delivery, 35, 36 weeks gestation. Hemoglobin level outside the normal range for pregnancy should be investigated and iron supplementation considered is done. A full blood count diagnosis is done with the help of full blood count parameters. Classic hypochromic microcytic picture by the obscured by physiological changes in pregnancy. Serum ferritin accurately reflects iron stores. Initial rise early in pregnancy, then progressive fall to 32 weeks. Level less than 50 gram per liter indicate of iron deficiency at any stage of pregnancy, and treated level less than 30 gram per liter indicates early iron depletion. Here are symptoms: colony, spoon-shaped nails in iron deficiency, anemia, paler skin and mucosal layer, conjunctival pallor, and contraindication for pregnancy. If your patient came to your office with suspicion for pregnancy at earlier than 12 weeks gestation and the hemoglobin level is less than 70 gram per liter, it is risky for fetal complication. In the first trimester even. Thus, it is indication to terminate pregnancy, and we had to get agreement. So, management: explain anemia, why she needing treatment, what about diet, and so on and so on. Trial of oral iron therapy. Ferrous salts are mostly used by WHO protocol, better absorbed than ferric salts. Dose: 100 to 200 milligram elemental iron per day. Repeat full blood count in 2 to 4 weeks. Response typically seen in 2 weeks. Increase in 10 gram per liter demonstrates effective treatment and compliance. But even if you got this effective response for treatment, you should not arrest further management. Here represented drugs which you will use for treatment: ferrous fumarate and dose. Drugs: dose per day in tablet and elemental iron containing at any tablet by WHO. and parenteral aerotherapy. Used nowadays, Cosmofer, Venofer, Monofer, Ferinject. I propose to learn drugs. I propose to learn DOS. These are drugs and DOS, even brand name, which are used just in your country, not in our country exactly. Direct therapy. Direct had to contain higher level of ferrin, of iron. If it is iron deficiency anemia, but that had to contain some adequate level of vitamins. As about red cell transfusion, we already told about it during our practical class. Blood transfusion is done in clinical emergency when she has massive obstetric hemorrhage. When she just closely to the liver and liver means beginning of bleeding, but she has excessively low level of hemoglobin. If she will lose some additional portion of blood, her RBCs will not be able to perform their function to transport oxygen, to support this oxygen transportation just for few days, not more than 5 days. We can try to make blood transfusion, and nowadays we are trying to make fresh RBCs, specially prepared partial components of the blood. Management during labor, comfortable position, adequate analgesia, oxygen inhalation, low threshold of assisted delivery, asepsis, and prophylactic administration of prostaglandin to minimize blood loss. Management postpartum, continue aerotherapy for 3 months after delivery. Prophylactic antibiotics had to be administered for this patient and appropriate contraceptive advice. Don't leave this patient without your observation, without management, even not only in postpartum period but after the end of postpartum period. Your main idea to make treatment of anemia to improve your general condition and manic condition prior to the beginning of the next pregnancy, especially if she is breastfeeding mother and she has anemia and you will not administer appropriate treatment after the end of postpartum period, both mother and her child would suffer from this situation. And liver diseases in pregnancy. Hepatic disorders in pregnancy may include HELLP syndrome, which appears as a result of preeclampsia, eclampsia syndrome, and not only as a result of preeclampsia, eclampsia, pre-existing hepatitis, and jaundice in pregnancy. Now, as about we have time which is closely to the end. Pay attention, please, to the acute viral hepatitis. Hepatitis A occur early in life, transmitted by infected person, infectious at end of incubation period and during pre-ecteric stage. And if pregnant woman becomes infected with hepatitis A, her baby is not affected. Intrauterine transmission of hepatitis A is very rare, but perinatal transmission can occur. Serum hepatitis A virus immunoglobulin M should be checked for all patients suspected of having hepatitis A infection and may persist for up to 6 months after acute infection. How it is influencing the pregnancy. Premature contractions, placental separation, premature rupture of membrane, vaginal bleeding, abortion. As about treatment, hepatitis A vaccine can be used in pregnancy. Anyone traveling to endemic area should receive the vaccination 2 times, 4 to 6 months apart. So hepatitis A means that pregnancy is not prolonging, or pregnancy is not contraindicated. The risk of affecting is mild. Hepatitis B virus infection acquired in adulthood leads to chronic hepatitis. Pregnancy neither confers a high risk of chronic infection nor a worse clinical cause of hepatitis. Hepatitis B have a high rate of vertical transmission, causing fetal and neonatal hepatitis. Additionally, maternally and neonatally transmitted HBV infection predisposing to liver cirrhosis and hepatocellular carcinoma in young adult. Diagnosis: checking for presence of HBV DNA in serum. Impact as similar. Prevention. Hepatitis B immunoglobulin 5 milliliter, ideally within 72 hours of exposure, and recombinant hepatitis B vaccine, 7 days of exposure. Alpha interferons, lamivudine as antiviral treatment. Hepatitis D, the major cause of chronic hepatitis, is an RNA virus causing chronic infection, transmitted parenterally. It is vertical transmission, infusion, and sexually. Vertical transmission is happened too. Incubation 3 to 4 months. Diagnosis should be measured and confirmed with serum HCV RNA positive. It is leading to miscarriage, premature labor, congenital abnormalities, worsening of maternal genital condition in second and third trimester of pregnancy, vertical or perinatal transfer may take place. Management in pregnancy of hepatitis C treatment includes ribavirin, which is teratogenic and hence contraindicated during the pregnancy. No vaccination is viable for hepatitis C prophylaxis. Thus, termination of pregnancy at early term of pregnancy is more appropriate if it is happened after the possibility to terminate its cesarean section had to be done in late terms of pregnancy. And at last, hepatitis D. Asymptomatic cause happens twice more often in non-pregnant women. 2 variants co-infected with HB, hepatitis B, superinfection in established chronic hepatitis B. Symptoms are presented here, and chronic hepatitis. Chronic hepatitis, especially with cirrhosis, impairs fertility. When pregnancy occurs, the risk of spontaneous abortion and premature labor is increasing in number of folds, but risk of maternal mortality is not. Despite standard immunoprophylaxis, many neonates of women with a high viral load are infected with hepatitis B virus. Data suggests that antiviral drugs given during the third trimester may prevent immunoprophylaxis failure. Fetal exposure should be minimized by using intraviral drugs only when women have advanced hepatitis or hepatic decompensation is a risk. Lamivudine, cilbuvudine, tenofovir are most commonly used. Corticosteroids given to treat chronic autoimmune hepatitis before pregnancy can be continued during pregnancy because fetal risk due to corticosteroids have no provided to access those due to maternal chronic hepatitis. So, azathioprine and other immunosuppressants, despite fetal risks, are sometimes indicated for severe diseases. So the lecture is over. Time is up. Thank you for your attention. Meet you later during the course of lecture in our department. Be healthy, please. Take care of yourself.